Hello and welcome back for episode 44 of the Newbie Dentist podcast. I'm your host, Dr. Omid Izami. In this episode, I am proud to have back a friend of the show, Dr. Davey Alleman, who actually becomes the first repeat guest on the podcast. And our first episode together, which was episode 30, Introduction to Biomimetic Dentistry, has become the most downloaded episode of the podcast series thus far. And that is why I'm super excited to be having Davey Alleman back for the next two episodes and talking more biomimetic dentistry, talking how to raise your game in restorative dentistry and how to produce long-lasting direct restorations, which, let's face it, for a lot of the new grads, for a lot of dentists in general, is pretty much the bread and butter of dentistry, and we need to really be able to execute these restorative procedures at a high level predictably. In this episode, we just jump right back in. We talk about different restorative procedures, different bonding protocols, and towards the latter part of episode 2, which I should release in a few days' time as well, we kind of have some fun and pull together some hierarchies of ranking of rubber dam versus no rubber dam versus which bonding system you use versus bulk fill versus layering composite techniques. We just really kind of went on and we recorded about an hour and 30 minutes. So that's why I've kind of broken it up into two episodes for you guys so you can consume it in more digestible lengths. So please, if you have heard the previous episode, be sure to check it out before you listen to these two upcoming episodes. Again, the first time we had Dr. Davey Alleman on was episode 30 of the Newbie Dentist podcast in an episode called Introduction to Biomimetic Dentistry. As always, please reach out to me on Instagram at NewbieDentist. If you have any questions or feedback, I do love to hear from you guys. And if you are a fan of the show, please be sure to rate us and subscribe on iTunes. It really does help the show get more exposure and grow at a faster rate to reach more people. Also, if you do enjoy it, there's no better compliments than, referring the show and showing these episodes to your friends, classmates, and colleagues. And for those of you who have been doing that and reaching out, I really do appreciate the support, guys. And I'm excited to bring you guys some fantastic content over the next little bit. So without further ado, I hope you guys enjoyed this episode with Dr. Davey Alleman.
Hello, and welcome to the Newbie Dentist Podcast, the safe place for newbie dentists to connect, collaborate, learn, and grow. The Newbie Dentist Podcast aims to provide high-quality and high-value content for all the newbie dentists out there. With your host, Dr. Omid Izami.
So I'm here with Dr. Davey Alleman, who is back for a second episode after a pretty successful episode 1, Introduction to Biomimetic Dentistry. We chatted about a lot of topics, and certainly I think for me personally, it changed the way I've been kind of doing my fillings and looking at adhesive dentistry and rubber dam and things like that. And I've heard a lot of good feedback from other people as well who've kind of learned a lot, took down some notes, and kind of changed the way they're doing things. So Davey, thanks a lot for coming back on. I know you're in a busy period with your life and kind of transitioning in your practicing world. So thanks for coming on again.
Well, I'm really happy to be here. It's kind of a flip of the coin. Last time you were transitioning from Canada to Australia, and now I'm kind of getting ready to finish up my Army obligation and head to, I don't know. They say greener pastures, but it's probably not. Whatever.
Where are you going to be working? Have you lined up work? Are you working with your dad?
Yeah, so I'll be working with my dad in just outside of Salt Lake City.
Yeah. Okay, that's exciting. So it's like a full biomimetic practice, or?
Yep. The plan is to never cut a tooth down for a crown.
I like it. So tell me a little bit. I mean, last time we didn't get too much into like the, maybe the financial or business side of things. I just want to quickly ask you about that, because something that, since we talked last time, I've been a little bit more, thoughtful of my restorative dentistry and adhesive dentistry and things, but it's really time consuming. So fillings, I used to take me, maybe like 40 minutes or something to do like a quadrant. Now I'm like spending an hour and a half or like hour and 40 minutes sometimes to do things. So in terms of, reimbursements and time spent and things, what have you found? I know you're, in the Army, maybe that's not a big concern because you're not necessarily, I don't know how it works, but I don't know if I'm sure you're not charging people for the procedure. So how is it going to be for you, or what have you found with people that you talk to that do this type of dentistry?
So the biggest thing is you have to really educate the patient that what you're doing is totally different than the dentist down the street. And it can start with just as simple as, hey, I'm going to put a rubber dam over your teeth. We don't use the word filling. That's the F word. It's a curse word, in my language. But the main thing is you just got to say, to do good dentistry takes time. And as you become more conscientious of the work that you're doing, and if you are documenting cases, then all of a sudden you will understand that there is no shortcut to fixing a tooth when it's structurally compromised. Now, when I say structurally compromised, that just indicates that when the tooth is under function, that the tooth is bending and flexing more than a natural tooth. And patients will understand that in order to save more of your tooth, we're going to have to employ techniques that are different than what got your tooth into that position to begin with. And it's usually a previous restoration, correct? So I try and always refer to my work as restorations rather than fillings. And the most important thing is that you get the skills and the techniques that you can charge for your time, because there are techniques that will allow a direct restoration last as long as an indirect restoration. But unless you understand how to stress relieve that restoration, then it'll have a lower longevity, if that makes sense.
Yeah, that makes sense. And, that's some of the stuff that we talked about last time with the, obviously like the layering. The one big thing that is kind of resonating with me a lot was like, after you do that first sort of layer, you put your etch and your bond and a little bit of flow, but you need like let it sit for a little bit of time before, just to allow that bond to like mature before you kind of start stacking the other layers on top. So what other factors are there in that like stress relief that you talked about?
So I want you to think of like a can of soda. So before you've opened a can of soda, and let's say you drop that can of soda, or better yet, let's talk a bottle. A bottle's a better example. So what builds up in that dropped can of or dropped bottle of soda?
It's pressure,
right? And so if you decide to open it right after you've shaken that bottle of soda, or you drop that bottle of soda, what ends up happening?
It shoots everywhere.
And so the pressure or the stress that's accumulated in that bottle of soda now has to escape somehow, right? Now, if you let it escape fast, right after it happened, what's going to happen to you?
It's going to make a mess.
It's going to make a mess. It's going to get all over you. But that's just, the physics of, a carbonated beverage under pressure, is that if you relieve that built up pressure, it's going to, explode. Now, what happens if you wait 20 minutes before you open that?
It calms down. The pressure.
Maybe it'll still, fizz out, but it has time for the pressure to diminish. Does that make sense?
Yeah. Great analogy.
And so it's the same thing with a polymerized restoration. So I don't care what anybody says. It's like, you're not going to eliminate all the polymerization stress in a restoration. But what you can do is you can control for the time that polymerization reaction and that stress dissipates. So if you decide to place your adhesive and do a quick fill and then light cure it, it's just like opening a bottle of soda after it's been shaken. And what ends up happening is that stress and that needs to be relieved. And where does it typically delaminate or relieve the stress? Right at the bonded interface. Or in really bad materials and very weak materials like a glass ionomer, it'll actually crack in the restorative material. So neither of those are great solutions. But if you allow the bond to mature, and then if you slowly layer your composite in low C factor increments, then that polymerization stress will dissipate more, and there'll be less strain and forces pulled on the rest of the tooth. Does that make sense?
Yeah. So just to review from last time, so you said, with the layering technique, the best way to like lower the C factor, is not necessarily like the oblique composites, just to do like thin, flat increments. Is that right?
Correct. So when you're thinking about a cavity prep, there's what my dad has referred to as the hierarchy of bondability. So in different areas of the tooth, there are different bond potentials that can influence where the polymerization will want to move towards. So anytime that you shine the light and you cure a material, composites, it's dumb. It wants to do whatever the laws of nature want it to do. And it'll tend to go to areas that are dry or quick forming. And so, when people will say, oh, the best bond is to enamel, that's a false statement. But it really depends on, how do I say this? It wants to go to the fast bond, and the fast bond is enamel because there isn't any pulpal fluid that it's competing with, and there's no collagen. But if you allow these monomers to infiltrate and to really adhere to a tougher material rather than a brittle material like dentin compared to enamel, then the bond potential can actually be towards the dentin rather than the enamel as far as the higher bond. And so,
interesting.
So the deeper that you go into a prep, what are you dealing with?
Dentin, like bigger tubules and stuff?
Exactly. So the lumen size of the dentinal tubule will be 2 times or even 3 times the size as the tubule size closer to the DEJ. So you have the potential of more pulpal fluid being entered into your bonding field, correct? And then what else do you have the deeper that you go into a tooth? So you're going to have more organic material rather than inorganic. Okay. So there'll be more collagen and less hydroxyapatite encrusted collagen. Does that make sense? So the deeper you are in the tooth, you have more organic material that you have to bond to, more collagen, and less dry material like hydroxyapatite or hydroxyapatite encrusted collagen crystals like you do in superficial dentin. So the bond strength in deep dentin is different than the bond strength to superficial dentin, and it's different than the bond strength to enamel. Now, each of these have different bond potentials, but they're all time dependent. And so if you can allow the slower maturing bonds a head start before they're stressed with a restorative material, then you're actually able to stay bonded in these deep preps.
Okay, so time is a big factor. So is it still like that remains like the 5 minutes you get like 90% of the maximum bond strength, like you're saying last time? Is that a pretty good rule to kind of practically live by?
Yeah,
in terms of these restorations.
It is I don't know. It would be like one of the unwritten rules of biomimetic dentistry is that you need to allow time for your bonds to mature. In every prep, you're not going to have ideal material to bond to in every area of the prep. And so if you live by this 5-minute rule, then you're giving those areas where you're bonding to maybe some outer caries or inner caries time to fully mature. And even though that bond potential will be a lot less than certain areas that are caries free, it will be able to withstand the polymerization stress on top of it.
Okay, that's good. That's what I've been doing recently. So say, for example, if I've been like doing a quadrant, like I'll prep like the 3 or 4 teeth that I'm working on, and then I'll do that base like resin coating layer like on the deeper ones first, and then I'll go and finish off the other fillings, and I'll come back to it. Just allow as much time as possible. So I found that a pretty good workflow.
Yeah, and that's the best way to be efficient in restoring these teeth. And so it's not, you can either, have a hard stop with a timer that says, okay, we're not going to put any restorative material in this preparation until, my 5-minute timer goes off, or a 7-minute timer, whatever you want to, time it. Or you can go on and work on the next tooth. And if you were working on the next tooth, then you're allowing that bond to form in a stress-free environment. That is the correct thing to do. And I'm really glad that you've been able to kind of switch some of your thought processes, from the last time that we interviewed, and implement, something that will benefit the longevity of your restorations.
Yeah. Another thing I want to kind of talk to you about today, and then I put that kind of poll out on Instagram as well. Something that I've been where I work, I work in a pretty some lower socioeconomic kind of areas. There's a lot of teenagers or early 20s with really bad caries, and we have these bombed out teeth that there's a little hole in the occlusal, and then I open it up and it's really deep. So I've been kind of struggling a little bit with caries endpoints, like when to stop, where to stop, how much of that soft stuff to leave where the pulp may be, to just try not to expose. And luckily, just anecdotally, the ones that I've been doing, and then I follow them up for the next quadrant, a week or 2 weeks. It's not very often that people complain of post-op sensitivity or anything like that. So from that regard, I'm pretty happy with it. But in terms of just longevity and future pulpal health and things, what's your thoughts on the caries endpoints and when to stop, where to stop, and kind of those type of things?
So when I stop is based solely on measurements, and these measurements are the ones that were published in the 2012 paper by my father and Pascal Monnier. And that's talking about 5 millimeters from the occlusal cavo surface, pulpally, and then going interproximally 3 millimeters from the marginal ridge of the adjacent tooth. And so as it goes, it starts to constrict, you can just take a perio probe, lay it flat, and you can measure 3 millimeters from that. Or my favorite technique is to actually know the width of my burr, and my favorite burr to use uses about a 0.16 round diamond, so 1.6 millimeters. And in these deep boxes, if I'm just there's basically no enamel in these deep boxes. And so if I'm cleaning with that 0.16, I'm cleaning about 2 millimeters axially. And if I stay in that safe zone of that diameter of that burr, I'm just not going to expose a nerve on the axial wall. I mean, I think I'm in the minority. I don't use a lot of slow speed. Most of my preparations are with high speed, and I go solely off of my caries indicator and the stains that's giving me, and then I stop at the measurement, and then just make sure that peripheral seal is completely clean, where there's no pink and no red. And if I see no pink and no red, then I know that there is no denatured collagen in that area. And when I bond to that area, the hierarchy of bondability will be anywhere between 40 and 60 megapascals. Whereas the pink and the red, I will have much lower bond strengths, but the benefit of removing that diseased tissue doesn't outweigh the benefits of, a potential pulp exposure.
Yeah. That's really cool. So is this based, are these measurements just based on average anatomy of that's your safe zone, 5 millimeters occlusally, 3 millimeters approximately?
So the best thing to do is to save some of your extracted teeth, cut them and then measure from, a cusp tip down to a pulp horn, and it's about 6 millimeters. And, if you stop at 5 millimeters, then, you have, a millimeter of dentin to play with. So if you're maybe measured a little bit poorly, then you still have a little bit of wiggle room or not. So that's where that cutoff point of 5 millimeters and 3 millimeters is, just because if you're cleaning 2 millimeters inside the DEJ aggressively, there's no real risk of pulp exposure. And I would say I have about 1 pulp exposure every 3 months. Yeah. And, I work on a lot of soldiers who have really, really awesome oral hygiene habits, just like some of your patients.
Yeah.
And, you're just you know that you're going to not have a caries-free caries removal endpoint for your entire prep. But if you can be caries-free in the critical areas, you can have a highly bonded perimeter to protect the lower bonded inner and outer caries that you're bonding to. And so if you're not using caries detecting dye or using a diagonodent to confirm your caries removal endpoints, then you're not achieving the predictability that can be achieved. And
okay, what's the sorry to cut you off there. What brand of caries detector dye do you recommend?
So the original caries detecting dye was invented by Takao Fujiyama, and he's also the father of adhesive dentistry. He's the one that showed us that bonding to dentin was possible. And the reason that he developed this breakthrough technology in the late 70s was, a dental student just asked him, hey, how do I know when to stop? Just like you just asked, right? Yeah. And the sensei, the teacher said, just go till it's hard. And then the student's like, well, how hard is hard?
Yeah.
And being humble, instead of just blowing off the student, he said, well, let's try and figure out a more predictable way that actually shows us when we're at a caries-free spot. And so the original formula was developed by Takao Fujiyama, and Kurare dental manufacturer developed it. And a little history on how it got FDA approval in the United States is Dr. Ray Bertolotti said, I can help you guys get caries detecting dye, into the United States and FDA approval if you let me in on your secret on how to manufacture it. And so Dan also makes a caries indicator that is identical to Kurare's caries detecting dye. But Ultradent makes a good one, Seek. But my preference is the original. It's red.
Yeah.
Some people find that a little intimidating, but I just say practice measuring, increase your magnification, and I promise you, red and pink and pulp will look different.
Yeah. So in those cases where you do expose pulp, what's your protocol and management there? Or is it just straight to endo? Or do you try and do
the first thing I do is I swear.
Yeah.
And then I tell myself that I won't tell my dad that I let him down.
Yeah.
Because he'll be like, well, did you measure? Yeah, I did. But the protocol that I use just is based off of the same principle as I'm doing with these indirect pulp caps. Is if I can create a perfect seal in those 2 millimeters of dentin and 1.5 millimeters, 2 millimeters of enamel, then the pulp has a capacity to heal itself. And a researcher named Charlie Cox did some very good research on direct pulp caps with dental adhesives. And he showed that if you can keep the tooth sealed where you're not having micro leakage and a free way for the inflammatory process to continue, that there's a lot of these cases where the pulp will heal. And so I don't prescribe that you need to, put a particular product over a pulp cap, because the most important thing that you should do is you should never expose the pulp.
Yeah.
Now, if you do, what you can do is you need to get the bleeding to stop. Does that make sense?
Yeah.
And so I've done in the past, I've taken, 50,000 parts of epinephrine lidocaine on a cotton pellet, let it sit on the on the exposure or you can take a little bit of bleach on a cotton pellet, put it on there, get the heme to stop. And then I just go ahead with my bonding protocols. Mm-hmm. So I will, prime the tooth, and then I'll place my adhesive. And it might not be a bad idea to, when you're curing your adhesive, when you have an exposure, to kind of do a quick tack cure, mm-hmm. and then do another second coat over the exposure. That way you're not overheating the pulp. I typically just do a full cure, but if you're using some of those high powered lights, that's not a bad idea. But Charlie Cox, he's published these studies, and one of them he showed histologic slides of these pulps that were exposed, and doing a direct pulp cap with a self-etch adhesive. My preference is either SC Protect or SC Bond. SC Protect has a nice antimicrobial component to it, which is beneficial if you have exposed a nerve. But I'll always tell the patient, look, I just tripled the chance of this tooth having to have a root canal because I drilled too much. But if you do, MTA is a good material. I wouldn't necessarily recommend DiCal or necessarily a resin modified glass ionomer, but if you can kind of keep your pulp exposures to a minimum, and a mild self-etch adhesive, you're going to be able to, you're not going to negatively impact the tooth by doing, just a direct pulp cap with an adhesive. Now, this is controversial and not taught in dental schools, but I've met Charlie Cox on multiple occasions. I've read a lot of his work, and I tend to believe people that are smarter than me.
That's a good way of kind of.
But the most important thing is don't expose.
Don't expose. That's the rule number one. Yeah. What about cleaning your cavity preps? Some people just rinse it with water. Some people use chlorhexidine. Any of those things that you routinely do at all, or any recommendations around that?
So when you're getting ready to bond, you will have endogenous proteases that will actually decrease the strength of your bond up to 25 to 30% after a year. And so there's been some nice studies showing chlorhexidine to deactivate these MMPs that will degrade the bond. Yeah. And so that's not a bad technique, especially if the adhesive that you're using doesn't do anything for those MMPs. Because if you would just ignore those, your day one bond will be different than your day 365 bond. Mm-hmm. But if you properly treat these MMPs, then your initial bond strength that you got on day one will be very similar to the bond strength that you got a year from that time. And so using chlorhexidine is a biomimetic strategy to maintain a bond long term. So the idea of using it for a disinfection, I don't really worry so much about that, because bacteria will go to sleep if you have a good seal that doesn't have any food. It's not sipping on a Mountain Dew,
Yeah.
But that process of placing chlorhexidine can be redundant if you're using certain adhesives that can deactivate those MMPs. As far as all right, let me just think about the question. So the question was what I'm doing to condition my prep.
Yeah, so the prep's all finished, and you're like, okay, I want to start bonding it now, like do the bonding protocol. Like, do you do something between when you finish your prep, like you've removed your caries detector and like you're happy with your caries like endpoint where you're at? Are you doing anything between that step and starting the bonding protocol?
So my question to you is, Omid, is what adhesive are you using?
Yeah, so I'm using like the 3M like Scotch Bond most of the time in one of my practices. So not the best, I know. And then my other practice we have it's like G Premio Bond. It's like, again, it's like one bottle. So I'm not, most of my places, I don't have a separate like prime and bond that I'm doing, which I can see your face at now and you're not too happy, but.
You're killing me. You're killing me.
Yeah.
I mean, your dental school, you had
Universal.
Bond, I mean.
Universal. Yeah, I know.
Okay.
We need to get back to it.
So if you're using either of those adhesives, you need to use a chlorhexidine 2% to before you bond. But before you even do that, I would recommend that you air abrade the prep. So
yeah, I'm doing that at least.
Okay, I want you to think about when you prep a tooth, what is the surface of the cut dentin? What are you dealing with?
Like exposed collagen tubules?
Well, yeah. So you've cut a bunch of stuff, right? And you got kind of
it's like debris.
You've got debris. Now, if you're using a total etch system, the strength of the acid will be strong enough to penetrate that thick smear layer, and so your primer is still effective. Whereas if you're using a self etch system, that acid is a lot less milder. It's a lot milder.
Yeah.
And so it's going to have a more difficult time to penetrate that smear layer. Now, the best way to compact that smear layer and to remove some of the really loose, fluffy kind of stuff is air abrasion. And so it compacts that smear layer, and we'll actually use some of that smear layer to kind of plug those tubules. How, and if you can do that, then you still have all of the benefits of a self etch, and it's able to penetrate and to slightly demineralize the hydroxyapatite around the collagen fibers. Does that make sense?
Okay. Yeah. So for example, let's just like walk through the situation. So I've done your prep. I'm using chlorhexidine. Do you just apply it and then dry it and then you go on with your, like, do you do this after you etch, or when do you do what's like the sequence of it?
Okay. So do you use your Scotch Bond Universal as a self etch or a total etch, or how do you?
So normally, I'll go through mine and maybe we'll go through yours and see like where we differ and pick up some tips. So normally, like I've done my prep, it's like sandblast or like air braided, and then I do total etch, and then I put the Scotch Bond and cure.
Okay, so you're using it as a kind of a etch and rinse, 2-step system. And so if you're doing it that way, you would etch and rinse, and then place your chlorhexidine, and then lightly dry, and then place your adhesive. So when you place the etch, it'll actually the acidic component will actually upregulate those proteases, those MMPs, and cause some issues. So if you're using a total etch, you should place your chlorhexidine after you etch and before you prime. Whereas if you're using a self etch, you would place your chlorhexidine before you place the
primer.
Does that make sense?
Yeah, that makes sense. So you never rinse it off. You apply the chlorhex and then just kind of air dry it.
Yeah. Now, when you're dealing with a total etch, you have to kind of worry about like over drying, that kind of stuff. Whereas if it's a self etch, there's no such thing as over drying because it's so mild, and you're not going to have the collagen scaffold kind of collapse on itself.
Yeah, so it's a little bit more tricky. So you're normally, what's your so let's just, for the listeners, say you're doing a lower molar, like large, deep occlusal. Talk to me like through your whole process, if you don't mind, like how you kind of go from you're happy with your prep is at to finishing off the restoration.
So the first thing I do is, anesthetize the patient.
Yeah.
And then I'll place my rubber dam. I joke with my assistant that, we've got two jobs, and one is that, always have music playing, and the other one is to help me put the rubber dam on. Yeah. And after that, she can go to sleep. But the most important thing that I'll focus on is, my caries removal endpoint. So I don't want to, gloss over that. The most important thing in a biomimetic restoration is your caries removal endpoint and not exposing the nerve. And so I will go until my peripheral seal zone is caries free. And the way that I determine caries free is not by a subjective hard, soft feeling, but rather an objective one where I'm using a caries detecting dye and I'm removing all pink and all red stain 2 millimeters inside of the DEJ. Yeah. And once I've gotten that, I'll assess the depth and see if I need to go, further pulpally or axially based off of the parameters that I still have to go with there. And then after that, I will air abrade the prep and then rinse and dry really well. Now the adhesive that I use is SC Protect. It's a 2-step self-etch adhesive. And so there's been studies that show if you actually dry the tooth prior to using a self-etch adhesive, you will increase the bond strength, an additional 10%. And so I'll air dry the tooth, pretty well before I begin my priming step. With SC Protect, there's a monomer called MDPB, and it's the monomer that Courare developed after MDP. So everybody's heard of MDP, right? Yeah. And every dental manufacturer is like, our adhesive now has MDP, right? Scotch-Bond Universal, it's got MDP. We can bond predictably, which has never been something that 3M could say honestly. So as bad as I think Scotch-Bond Universal is, it's better than some of the other Scotch-Bonds.
Yeah.
But the reason why everybody's using MDP is because the patent expired 3 years ago. And so it isn't a new technology. It's not a new monomer. But everybody recognizes that that's what made SE Bond such a breakthrough adhesive. And the adhesive right after SE Bond that Courare manufactured was SE Protect. And the monomer MDPB has 2 additional carbons and a functional monomer of pyridinium bromide. And this pyridinium bromide is antibacterial and will actually deactivate those MMPs. And so you don't actually need to use chlorhexidine if you're using SC Protect, because it kills bugs and it also deactivates the MMPs. And the lead researcher on that is Imosato out of Japan. And so what I'll do is I'll air dry my dentin for 10 seconds. Then I'll prime it. I'll prime for 20 seconds. And there's no way you can over prime a tooth with like SE Bond or SE Protect. And so, I'm just being a little OCD whenever I'm priming the tooth. That's like the most important part, because I really want to get, these hydrophilic monomers encapsulating the collagen fibers. And
so you're like scrubbing pretty hard with like the microbrush?
Yeah, I'm just, making sure I'm getting all the surfaces, very, very well. And then the next question is, how do I get the solvent that's carrying these hydrophilic monomers in my primer, out? And so what I'll do is I'll air dry that very, pretty aggressively for about 10 seconds, where I have my assistant with the suction, where I'm getting negative aspiration, and then I will air dry the prep as well. And then when the dent is, fairly shiny and I'm not seeing any fluid movement of additional primer, then I'm ready to bond, and I'll take, my adhesive, and I'll place my adhesive. I don't air dry it. There's no solvent. There's no reason to air dry a bond.
Okay. So you don't need to thin it out or uniform it.
No, you do want to get it uniform, because it will be radiolucent if it pools, especially against the band. And so taking a dry brush is the best way to wick away that excess. But I don't want to introduce air into my adhesive. As soon as I introduce air into my adhesive, or I thin my adhesive out, there's a possibility that as the polymerization of my adhesive happens, that the air interaction will create an unbonded film. We've all heard of the oxygen inhibited layer, right?
Yeah.
And so if you've got this unbonded film and you're in a deep prep, then there is a possibility that you will have transudation and you'll have irregularities in your hybrid layer. And this is one of the reasons why I'm very against really thin adhesives, because your air inhibited layer is not insignificant, and you can easily air thin an adhesive to the point where you're getting zero bond before you put your resin coat on top of it.
That's really interesting. So you apply the bond with a microbrush, and then you get another second dry microbrush and just kind of go over it. So
I usually just go right, in the box where I've already placed my my band, and I will just wick away any excess, or if there's an area that you could just see the adhesive pool, I'll just take a small dry microbrush and kind of wick it away. So
what about I've seen some people use suction, they'll bring the high volume suction after they've applied the bond instead of blowing air.
I would say that is
similar theory as the blowing the air.
I would say it's maybe a little bit better, but I would say it's unnecessary. There are some specific advantages of a thick adhesive, and the best adhesive that every manufacturer compares itself to is Optibond FL, and the thickness of Optibond FL is very thick. It's 80 microns compared to SC Bond, which is about 40 microns, and then everybody else is 10 to 20, and your air inhibited layer is about 15 microns, and so it can be pretty touch and go depending on what adhesive you're using. So the idea of a thick adhesive doesn't bother me, but I don't want a big radiolucency that if a dentist sees, they go to another dentist and they see, a little area where adhesive pooled up against my band, and they think, there's a large void or there's recurrent decay. Those are the main reasons why to wick it away.
Yeah. I'm here with Dr. Davey Alleman, who is back for a second episode after a pretty successful episode 1, Introduction to Biomimetic Dentistry. We chatted about a lot of topics, and certainly I think for me personally, it changed the way I've been kind of doing my fillings and looking at adhesive dentistry and rubber dam and things like that. And I've heard a lot of good feedback from other people as well who've kind of learned a lot, took down some notes, and kind of changed the way they're doing things. So Davey, thanks a lot for coming back on. I know you're in a busy period with your life and kind of transitioning in your practicing world. So thanks for coming on again. Where are you going to be working? Have you lined up work? Are you working with your dad, or what's the... Yeah. Okay, that's exciting. So it's like a full biomimetic practice, or I like it. I like it. So tell me a little bit. I mean, last time we didn't get too much into like the, maybe the financial or business side of things. Let's kind of quickly ask you about that, because something that, since we talked last time, I've been a little bit more, thoughtful of my restorative dentistry and adhesive dentistry and things, but it's really time consuming. So feelings, I used to take me, maybe like 40 minutes or something to do like a quadrant. Now I'm like spending an hour and a half or like hour 40 minutes sometimes to do things. So in terms of, reimbursements and time spent and things, what have you found? I know you're, in the army, maybe that's not a big concern because you're not necessarily, I don't know how it works, but I don't know if I'm sure you're not charging people for the procedure. So how is it going to be for you, or what have you found with people that you talk to that do this type of dentistry? Yeah, 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 yeah. Yeah, that makes sense. And that's some of the stuff that we talked about last time with the, obviously like the layering. The one big thing that is kind of resonating with me a lot was like, after you do that first sort of layer, you put your etch and your bond and a little bit of flowables. You need like let it sit for a little bit of time before just to allow that bond to like mature before you kind of start stacking the other layers on top. So what other factors are there in that like stress relief that you talked about? Yeah, it's pressure. Yeah. It shoots everywhere. Yeah, it's gonna make a mess. Yeah, yeah. It calms down the pressure. Yeah, yeah, yeah. Great analogy. Yeah, Yeah. 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 So just to review from last time, so you said, with the layering technique, the best way to like lower the C factor, is not necessarily like the oblique composites, just to do like thin, flat increments. Is that right? Mhm. Yeah. Yeah. Oh, interesting. Yeah. Dentin, like bigger tubules and stuff. Mhm. Yeah. Okay. Yeah. 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 Okay. So time is a big factor. So is it still like that remains true, like the 5 minutes you get like 90% of the maximum bond strength, like you're saying last time? Like is that a pretty good rule to kind of practically live by in terms of these restorations? Yeah. Yeah. Hmm. Yeah. Okay, that's good. That's what I've been doing recently. So, say for example, if I've been like doing a quadrant, like I'll prep like the 3 or 4 teeth that I'm working on, and then I'll do that base like resin coating layer, like on the deeper ones first, and then I'll go and finish off the other fillings, and I'll come back to it. Just allow as much time as possible. So I found that a pretty good workflow. Yeah, yeah. Another thing I want to kind of talk to you about today, and then I put that kind of poll out on Instagram as well. Something that I've been sort of, I mean, where I work, I work in a pretty like some like lower socioeconomic kind of areas. There's a lot of teenagers or like early 20s with like really bad caries, and we have like these bombed out teeth that there's like a little hole in the occlusal, and then I open it up and it's just it's really deep. So I've been kind of struggling a little bit with caries endpoints, like when to stop, where to stop, how much of like that soft stuff to leave where the pulp may be, to just like try not to expose. And luckily, just like anecdotally, the ones that I've been doing, and then I follow them up for like the next quadrant, like a week or 2 weeks. It's not very often that people complain of like post-op sensitivity or anything like that. So from that regard, I'm pretty happy with it. But in terms of just like longevity and future pulpal health and things, what's your thoughts on like the caries endpoints and like when to stop, where to stop, and kind of those type of things? Mm-hmm. Okay, interesting. Yeah, 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 yeah. Okay, yeah, hmm, yeah. That's really cool. So is this based like are these measurements just based on like average anatomy of that's your safe zone, like 5 millimeters occlusally, 3 millimeters interproximally? Mhm. Yeah. 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 Hmm. Yeah. Okay. What's the sorry to cut you off there. What brand of Caries Detector dye do you recommend? Hmm. Yeah. 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 So in those cases where you do expose pulp, what's your protocol and like management there? Or is it just straight to endo? Or do you try and do like direct capping and yeah. 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 Hmm. Yeah. 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 Mhm. Okay. Mhm. That's a good tip. Yeah. 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 That would be nice. Mhm. Yeah. That's a good way of kind of approaching it. What about don't expose? That's the rule number one. Yeah. What about cleaning your cavity preps? Some people just rinse it with water. Some people use like chlorhexidine. Any of those things that you routinely do at all, or any recommendations around that? Yeah. Hmm. Yeah. Yeah. Hmm. Yeah, so the prep's all finished, and you're like, okay, I want to start bonding it now, like do the bonding protocol. Like, do you do something between when you finish your prep, like you've removed your caries detector and like you're happy with your caries like endpoint where you're at? Are you doing anything between that step and starting the bonding protocol? Yeah, so I'm using like the 3M like Scotch Bond most of the time in one of my practices. It's not the best, I know. And then my other practice we have it's like G Premio Bond. It's like again, it's like one bottle. So I'm not most of my places I don't have a separate like prime and bond that I'm doing, which I can see your face at now, and you're not too happy. But yeah, it's a universal, universal. Yeah, I know. We need to get back to it. Yeah, yeah, I'm doing that at least. Like exposed collagen tubules. Yeah, it's like debris. Yeah. Hmm. Milder. Yeah. Yeah. Hmm. Okay. Yeah. So do you for example, let's just like walk through the situation. So I've done your prep. I'm using chlorhexidine. Do you just apply it and then dry it and then you go on with your like do you do this after you etch or when do you do the what's like the sequence of it? So normally, so I'll just yeah, I'll go through mine and maybe we'll go through yours and see like where we differ and we can pick up some tips. So normally, like yeah, I've done my prep. I it's like sandblast or like air braided, and then I do total etch, and then I put the Scotch bond and cure it. Yeah. Hmm. 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 Like primer. Yeah. Yeah, that makes sense. So you know, so you never rinse it off. You just you apply the Chlorhex and then just kind of air dry it. Yeah. Mm-hmm. Yeah. Yeah. So it's a little bit more tricky. So you're normally, what's your port? So let's just, for the listeners, say you're doing a lower molar, like large, deep occlusal. Talk to me like through your whole process, if you don't mind, like how you kind of go from you're happy with your prep is at to finishing off the restoration. Yeah. 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 Okay. Yeah. 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 Mhm. Nice. Mhm. Yeah. So you're like scrubbing pretty hard with like the micro brush, like you're going Yeah. Hmm. Yeah. Okay, interesting. So you don't need to like thin it out or like uniform it or yeah. Okay, interesting. Yeah. Interesting. Yeah. Hmm. Yeah. That's really interesting. So you apply the bond with a microbrush and then you get another second dry microbrush and just kind of go over it, just dab it around. Hmm. What about I've seen some people use like suction, like they'll bring the high volume suction after they've applied the bond instead of blowing air. How similar theory as the blowing the air. Hmm. Hmm. It's thick. Yeah. Hmm. Yeah. Yeah. Hmm. Yeah.